Unfortunately, there are no panaceas in lung cancer. I would fervently pray for some therapy to come along that will just be a cure-all, but that doesn't exist. Certainly in terms of going beyond just the incremental benefits, I'm holding out hope for immunotherapy combinations, and not necessarily just PD-1, PD-L1 inhibitors with CTLA-4 inhibitors, but other combinations that may really unlock the keys to, or unlock the immune system, that will provide the keys that will unlock the immune system. I think this is critically important. There are a number of ongoing phase 1 and early phase 2 trials that are looking at various immunotherapy combinations. We have to be mindful, though, that the minute we start combining immunotherapy approaches, the toxicity rates go up, and certainly we've observed that in initial trials of CTLA-4 inhibitors and PD-1 inhibitors. PD-1 inhibitors, PD-L1 inhibitors are relatively innocuous, but the incidence of immune-related reactions and side effects can go up exponentially. I think we're also beginning to slice up the pie further, at least for adenocarcinoma. We've now recognized EGFR mutations for over a decade, ALK translocation for 5 or 6 years or so, ROS1, 3 or 4 years. Just this year, we had quite a bit of data regarding MET mutations, exon 14, and HER2 mutations in exon 20. And while these only represent perhaps 1 to 2 to 3% individually of all patients with adenocarcinoma, for that group, for those small select groups, we may see major incremental benefits. Squamous cell is much tougher. The ongoing lung MAP trial is trying to do the same basic approach, slice up the pie, try to find specific molecular drivers that are targetable. It's an ongoing iterative process, and I worry that squamous cell, perhaps because of its high mutation burden, may be a lot more difficult to find specific oncogenic drivers.